menstrual disorders and correct menstrual disorders. Menstrual cycle. It is cyclically repeating change in the woman's body, especially in the reproductive systems, the external manifestation of which are blood discharge from the genital tract and called menstruation. The first menstruation, menarche, occurs at age of 10 or 12 years. During 1 or 1.5 years, menstruation can be irregular, but during the year, a regular menstrual cycle is established. Parameters of the normal menstrual cycles: duration from 21 to 35 days. Duration of menstrual flow is from 2 or 7 days. The amount of blood loss in menstrual days is 15 or 115 milliliters. Two-phase character, ovulatory phase, and cyclically, and the duration of the cycle is condensed. Menstrual cycle have regulation, and we know that regulation include 5 levels: cortex, hypothalamus, pituitary, ovaries, and target organs. Other levels of regulation, it is cortex and extrahypothalamic cerebral structure, limbic system, hippocampus, and amygdala. Neurons of the brain receive information about the state of the external and internal environment. Synthesis, isolation, and metabolism of neurotransmitters and neuropeptides. The synthesis and release of hormones, neurosecretors, and secretory nuclei of the hypothalamus. Hypothalamus synthesis liberin and statins. Liberin or releasing factors stimulate the release of appropriate trophic hormones in the anterior lobe of the pituitary glands, and we know 7 liberins: thyreoliberin, corticoliberin, somatoliberin, melana, foliberin, luliberin, and prolactoliberin. Statins have an inhibitory effect of their secretions. We know 3 statins: melanostatin, somatostatin, and prolactostatin. Anterior pituitary glands, adenohypophysis, very interesting, and synthesis 3 follicle stimulation hormones, growth and maturation of follicle in the ovary. Luteinization hormones. Together, this follicle stimulation provides a major egg from the follicle and stimulates the formation of progesterone in the yellow body. Prolactin, responsible for breast growth and lactation. Ovaries. What actions occurs at ovaries? Firstly, it is follicle growth and maturation, ovulation, the formation of the yellow body, synthesis of sex steroid, estrogen, progesterone, and androgens. Target organs. It is uterus, fallopian tubes, vagina, vaginal mucosa, mammary gland, cervix. We know about adipocytes cells. We know about skin and hair. It is target organs too. Classification of menstruation disorders: amenorrhea, cyclical change in menstruation, uterus bleeding, and oligodysmenorrhea. Amenorrhea, no menstruation for 6 months or more in women of 16-45 years. Severe form of pathology of menstrual functions. Frequency among women of reproductive age is 3.5%. The structure of menstrual and reproductive disorders is 10 or 15%. Classification of amenorrhea: true and false amenorrhea. True amenorrhea can be physiological and pathological. Pathological amenorrhea can be primary and secondary. At the level of the lesions, can be peripheral genesis and central genesis. If we talk about peripheral genesis, we have problems this of ovaries and the uterine. Central genesis, cortical hypothalamic, hypothalamic pituitary problems, and pituitary amenorrhea. Diagnosis of amenorrhea, collecting anamnesis, general inspection, date and special gynecological research, test of functional diagnostics, study of the levels of sex hormones, thyroid hormones, prolactin, follicle stimulation hormones, luteinization hormones, determination of sex, chromatin and karyotype, symbol progesterone, estrogen, progesterone, dexamethasone, craniography, CT of the brain, ultrasound of pelvic organs, and laparoscopy. Progesterone test allows to exclude detect the uterine form amenorrhea. Injection medroxyprogesterone 5 or 20 milligrams, progesterone 1% for 6 days. The menstrual-like reaction that appears after 2-3 days indicate the absence of the uterine forms of amenorrhea, or an obstacle to the outflow of menstrual blood, false amenorrhea. Combined estrogen-progesterone test. It is carried out with a negative progesterone test. Within 10 or 14 days, estrogenic drugs are administered and then pass to the introduction of progesterone. In the uterine form of amenorrhea, this sample is negative. Test this human chorionic gonadotropin. Enter 1,500 until of chorionic gonadotropin daily for 3 or 5 days. Throughout 10 or 14 days menstrual-like reaction is, if the ovary is positive, in primary ovarian deficiency negative. Simple with dexamethasone drops. Dexamethasone is prescribed for 2 milligrams a day for administration for 2-3 days. Small test. The big test, it is prescribed 8 milligrams of dexamethasone in 4 doses. Before and after the test, it's need to determine the excretion of 17-testosterone and 17-oxytestosterone of the contains in the blood. Reduction of these parameters by 15% or more, positive test, indicates hypoplasia of the adrenal cortical substance. The absence of change, negative test, edema of the adrenal cortical substance. In case of Cushing disease, the sample are positive, and in the Cushing syndrome, negative. False amenorrhea, cryptamenorrhea. The absence of menstrual bleeding in the presence of cycle process in the hypothalamic, pituitary, ovaries, and uterus line. Due to atresia, germination of the vagina, cervical canal, hymen. And this is picture give characteristics about form and atresia levels. A. Atresia of hymen. B. Aplasia of the lower and middle parts of vagina, and B. Aplasia of the cervix and vagina. The sections of the hymen in the process of increment. Firstly, it is cross-shaped incisions. Second, the edges of the incision are situate. Through amenorrhea, there are no cyclic change in the ovaries, uterus, hypothalamus, pituitary systems, no menstruation, except for patients who do not have a uterus or there are pronounced pathological change in the endometrium. Physiological amenorrhea. It is no menstruation this period, and firstly it is before puberty, during pregnancy, during lactation, in postmenopausal woman. Pathological amenorrhea is symptoms of genital or extragenital disease, organic and functional disorders at any level of the reproductive systems. Primary amenorrhea, no menarche after 16 years. Secondary amenorrhea, lack of menstruation for 6 months or more in a previously menstruated woman. Primary amenorrhea, amenorrhea due to gonadal dysfunction, gonadal dysgenesis, testicular feminization, primary ovarian hyperfunction, and amenorrhea due to extragonadal causes. The syndrome of dysfunctional feminizations. Gonadal and genetic sex male for 46XY chromosome. Phenotype female. Signs of the disease appear during puberty. External genital and development are hyperplastic. There are no uterus and fallopian tubes. The vaginal and bluntly gonads, testicle, are often located in the labia or in the inguinal canal. There is a dead of tumor transformation of gonads. The level of gonadotropin and androgens is increased. Treatment. Surgical removal of defective testicle is at the age of 16-18 years after completion of growth and development of secondary sexual characteristics due to the risk of malignancy. In the future, it should be cycle hormone therapy with estrogen and gestagen or oral contraceptive. The purpose of hormones therapy is the prevention of atrophic process of the mammary glands and genitals and prevention of post-castration syndrome. Gonadal dysgenesis, pathology caused by chromosomal abnormalities, but may be associated with gene mutation, lack of functional gonad tissue instead of ovaries, fibrous stents. Forms of dysgenesis gonadal depend on the phenotype and karyotype of the patients. Typical turn syndrome, clean, mixed, and arrest. Typical forms. It is characterized by abnormalities of gonads. These are small strands in the pelvic cavity, karyotype 45X0. Phenotype female. Short neck, wide leather fold, wing shaped on the neck. Low hair growth limit. Sexual infantilism. Defect in the development of bones, cardiovascular system, and other organs. Hypothalamus of the mammary glands. Few forms of gonadal dysgenesis. The karyotype is 46XX and 46XY chromosome. Phenotype female. No somatic deformity. Higher growth secondary sexual characteristics are almost absent. The uterine is rudimentary. Gonadal heavyweight may contain undifferentiated cells, sometimes subject to tumor-like degeneration. Mixed form of gonadal dysgenesis. Karyotype 46XY or mosaicism 46XY 45 X0. Characteristics female. Rarely male phenotype. These are intersex structure of the external genital. These are predominance of female type and varying degree of sterilization. Depending on that clone of cells, prevalence at the place of the ovaries may find over testis, ovarian head, dysgenesis egg. Often there is malignant degeneration of defective gonads. Irset forms of gonad dysgenesis. The karyotype is 46XX and 46XY. Phenotype female. Higher growth, secondary sexual characteristics are almost absent. The uterus is rudimentary. Gonadal heavyweight may contain undifferentiated cells, sometimes subjected to tumor-like degeneration. Treatment of gonadal dysgenesis. The treatment begins from 13-14 years. This estrogen continuously to increase the mammary glands and the appearance of menstrual-like reaction. Then cyclic hormone therapy is carried out from 7 days. Mycophenolate is prescribed at 0.05 milligrams per day for 15 days, then gestagen, progesterone 1 milliliter of 1% solution, narcoleptic 10 milligrams for 6 days. Is in mixed forms removal of gonad to exclude the development of malignant tumor. Secondary amenorrhea can be normogonadotropin, hypergonadotropin, and hypogonadotropin. The level of the primary lesions, the uterus, ovary, the pituitary gland, the hypothalamus. Uterine amenorrhea, Asherman syndrome, intrauterine synostosis, tuberculosis, endometritis, reasons, intrauterine interventions, abortions, childbirth, surgery, endometritis non-specific, and tuberculosis etiology. Treatment of uterine amenorrhea, surgical removal of intrauterine synostosis, physiotherapeutic treatment, and cyclic hormone therapy. Ovarian amenorrhea, the syndrome of the depleted ovaries, the resistance ovary syndromes, polycystic ovary syndrome, the realizing ovaries tumor. The syndrome of the depleted ovaries. Pathological symptom complex includes secondary amenorrhea, infertility, vascular disorders in women younger than 38 years, leaves normal menstrual and reproductive function in the past, has a hereditary character. The frequency in the population is 1.5%, and in the structure of secondary amenorrhea up to 10%. The etiology and pathogenesis of the depleted ovary syndrome. Chromosomal abnormalities and autoimmune disorders are expressed in ovaries damage. This deficit of the follicular apparatus, pre- and post-pubertal destruction of embryonic cells, primary damage to central nervous system and systems and the hypothalamic regions. The clinic of the syndrome of the depleted ovaries, oligomenorrhea, vegetative vascular manifestation, hot flash, sweating, weakness, headache, disability. Treatment of the syndrome of the depleted ovaries, cyclic hormone therapy with estrogen containing not more than 0.03 milligrams of drugs used in the therapy of climacterical syndrome, Climanorm, Climen. Therapy is carried out in cyclic 2 or 3 months and 1 or 2 months break to restore menstrual cycle, elimination of vegetative disorders, and prevention of osteoporosis. The resistant ovary syndrome, Savage syndrome, include amenorrhea, infertility, normal development of secondary sexual characteristics is micro and microscopically unchanged ovaries with higher levels of gonadotropin in women under 35 years. Frequency 1.9 before 10% of all forms of amenorrhea. Etiology and pathogenesis. Reasons are not studied. There is an opinion about the autoimmune nature of this pathology. Treatment: cyclic hormone therapy with estrogen, not more than 0.03 milligram can be recommended lower dose of drugs. Therapeutic as course 2 or 3 months, 1-2 months break. The realizing ovarian tumor. There are rare, amounting to 5 or 10% of the number of ovarian tumor. The tumor secretes all sex hormones, androgens. The feminization occurs and then the realization. The realization, the appearance of women's secondary sexual characteristics inherent in men. The feminization, it is characteristics by oligomenorrhea and amenorrhea and regressions of secondary sexual characteristics. Male type of hair. Functional disorders of the hypothalamus pituitary system. Syndrome of hyperprolactinemia, amenorrhea on the background of weight loss, stress amenorrhea, amenorrhea in medicamental amenorrhea. Hypothalamic amenorrhea, amenorrhea on the background of weight loss by 15% or more, 25 amount secondary amenorrhea. Anorexia from the Greek is negative particle Anorexia appetitis is a psychopathological syndrome manifested in the obsessive quest for weight loss. Anorexia is a female disease which manifests itself in adults. Treatment of amenorrhea on the background of the loss of body weight, the normalization of the diet, appointment of enzyme pepsin, gastric juice, vitamin of all groups, psychotherapy. The menstrual cycle is restored after the normalization of body weight, but may be unstable. Treatment of amenorrhea in anorexia nervosa. High-calorie food, introduction of 14% glucose solution, vitamin preparation of B, A, C groups, psychotherapy, neurotrophic agents, for example, seduction. If these 3 or 4 months of general treatment, menstrual function is not restored, cyclical hormonal therapy is prescribed. The course of treatment is 4 or 6 months. Hyperprolactinemia, the synthesis and exhalations of gonadotropin-releasing hormones, decrease in the hypothalamus and respectively luteinization and follicular stimulation hormones as a result of reduce the sensitivity of the hypothalamus to estrogen. In the ovaries, prolactin inhibit gonadotropin-dependent steroid synthesis, reduce the sensitivity of the ovaries to exogenous gonadotropin, as well as the secretion of progesterone by the yellow body. Causes of pathological hyperprolactinemia can be two groups, anatomical and functional. Talk about anatomical include pituitary tumor and injuries and radiation. Causes functional, chronic psychogenous stress, neuroinfections, endocrine disease, iatrogenic estrogen and estrogen contains oral contraceptive, galoperidol, using metoclopramide, sulpiridine, reserpine, opioids, monoamine oxidase inhibitors, hallucinogens, and amphetamines using. Clinic of hyperprolactinemia, change in ovaries function, anovulation, luteal phase insufficiency, menstrual cycle disorders by type of oligomenorrhea or secondary amenorrhea. 67% of women have galactorrhea. 15% of women report headache and dizziness, transistence increase arterial pressure. Treatment of hyperprolactinemia. In pituitary adenomas, surgical or radiological treatment. For the treatment of functional hyperprolactinemia using Parladel or bromkriptine, the drug is prescribed in a continuous mode at a dose of 2.5 before 7.5 milligram per day for a long time, more than 1 year if women need pregnancy before pregnancy using. This insufficient effectiveness against the background of its use, clomiphene citrate is used in 15 or 100 milligram for the first or 9 days of the menstrual cycle. In hypothyroidism, treatment is carried out with steroid hormones, thyroid or thyroidine. Pharmacological amenorrhea, no menstruation when taken, gonadoliberin agonist, for example, danazol, danol, danaval, zoladex, antihypertensive drugs, reserpine, dopegid, antipsychogenic drugs, sleeping pills, anticonvulsant and tranquilizer drugs. Pituitary tumor, empty, Turkish saddle syndrome, postpartum hypopituitarism, Sheehan syndrome, and pituitary amenorrhea. Postpartum hypopituitarism. It developed This necrosis change in the pituitary gland that occurs against the background of spasm or intravascular coagulation in the vessels of the anterior pituitary. Reasons: severe hypertension in pregnant women, bleeding, bacterial shock in childbirth or abortion. The earliest and most characteristic symptoms is the absence of breast causing after childbirth and agalactia, decreased gonadotropin and development secondary amenorrhea, decreased thyroid stimulation hormone, and development secondary thyroidism. Treatment of postpartum hypopituitarism. Prednisolone 5 milligrams 2 times per day for 2-3 weeks, cause 1 time in 2-3 months. Women under 14 years of cyclic hormone therapy after 14 years androgens, methyl testosterone 5 milligrams per day for 2-3 months. Anabolic steroids, retobalil, vitamin groups B, C, P, biogenic stimulations, uterine bleeding. There can 10 or 13% of women of reproductive age in premenopausal, their frequency increased to 15%. Make up 20-30% of all causes of women assessed to gynecological in the reproductive, pre- and post-menopausal 15-70%. It ranked second among the cause of hospitalization of women in gynecological hospital. Save as an indicator from 2 parts 3 of hysterectomy and endometrial ablation led to a decrease in the quality of women's life, physical, emotional, financial condition. To economic consequences stated this temporary disability and higher cost of treatment. Abnormal uterus bleeding, it exercise bleeding in duration, volume, and of frequency. By the nature of menstrual cycle disorders and morphofunctional change can be ovulatory bleeding and anovulatory bleeding. Anovulatory bleeding, single phase, short-term rhythmic persistence of the follicle, long-lasting follicle persistence, atresia of many follicles. Ovulatory abnormal uterus bleeding can be hyperfunction and hyperfunctions of the corpus luteum and hyperfunction and hyperfunction of the menstrual follicle. In the age aspect are distinguished: juvenile bleeding, bleeding of reproductive age, pre- and post-menopausal bleeding. Juvenile bleeding, pathological bleeding caused by the deviations of endometrial rejection and adolescent girl with impaired cyclic production of sex steroid hormones from the first menstrual period to 18 years. In girls, this menarche for 3 years, not related to specific gynecological disease, pregnancy, abortion, and childbirth. Predisposition factors constitutes asthenic, constitutes intersex, infantile types, increase allergy, unfavorable material, climatic and geographic factors, the impact of DMH influence in the ante and intrapartum period, frequent infection disease in childhood, flu, tonsillitis, and rheumatism. Enabling factors, mental shock, physical exercise, traumatic brain injuries, acute infection disease, lack of excess of body weight. Etiopathogenesis, the immature of the reproductive system, the defect of negative feedback, an increase in the Increase in the level of estrogen does not lead to a decrease in the secretion of follicle stimulation hormones, which in turn cause stimulation of growth and development of many follicles at onset and factors inhibiting the choice and development of the dominant follicle. The absence of ovulation and subsequent production of progesterone by the yellow body creates a state of chronic estrogen effect of the target organs, including the endometrium. This progesterone deficiency, the endometrium is not subject to secondary transformation and hyperplasia. Increase the sensitivity of the endometrium to estrogen while reducing the contractile of the uterus. The presence of necrosis tissue and blood clots in the uterine cavity contributes to spread of setting infection and the development of endometritis. Juvenile bleeding clinic. There are hypoestrogenism, hyperestrogenism, and normoestrogenism type of bleeding. We don't state this is characteristics. Diagnosis of juvenile bleeding. Complaints. The history of the development of life and disease, objectively inspections, hemodynamic status, definitions of the phenotype, characterization of the degree of sexual development, characterization of physical development, gynecological examination. This laboratory. Doctor, please turn up your microphone.
ميكروفون موهيت.
Determination of the hormones levels, follicles stimulating, luteinization, prolactin, progesterone, cortisol, testosterone, and blood and urine. Additional research methods, ultrasound, examination of pelvic organs, liver, adrenal gland, thyroid gland, radiography of this projection of the Turkish saddle, electroencephalography and radioencephalography and consultation this neurologist, computer tomography, consultation of the ophthalmologist, consultation of the hematologist, consultation of the endocrinologist, determination of bone age, X-ray of the hands. Stage of treatment of juvenile bleeding. First stage. Doctors, if you're tired, maybe I stop my lecture.
موهيت, please, your microphone.
No, doctor. Complete.
Thank you, doctors. First stage, treatment during bleeding. Second stage, prevention of recurrent of bleeding, normalization of the hypothalamic pituitary ovary systems. Initial type of therapy of juvenile bleeding stage 1. The creation of health protective regime, non-hormonal hemostatic therapy, uterotonic drugs that increase the contractile activity of the myometrium, physiotherapeutic treatment, reflexotherapy, drugs that stimulate blood coagulation potential, vitamin therapy, hormonal hemostatic therapy combine estrogen gestagen preparation, only estrogen and only gestagen drugs. Surgical treatment include firstly scraping of the endometrium and if talk about malignization, hysterectomy. Indication for hormonal hemostasis, heavy bleeding. Doctors, hear me?
Yeah.
Mhm. Heavy bleeding with moderate anemia. No effect of symptomatic therapy in moderate and prolonged bleeding. Long-term bleeding and the presence of the contraindication to diagnostic scrapping. Combine oral contraception for hormonal hemostasis, lower dose and higher dose. If talk about drugs with lower dose, using before 6 tablets. If talk about higher dose, using before 4 tablets per day. And if bleeding stop, we go in the contraceptive regimes. Contraindication for hormonal hemostasis, hypercoagulation according to coagulation, severe liver disease, acute or chronic persistent hepatitis or cirrhosis, in idiopathic hypercholesterolemia, biliary dyskinesia, hormonal hemostasis is prescribed this caution. Surgical treatment, scraping of the endometrium and extirpation of uterus without appendages. Indication for treatment and diagnostic curettage of uterus. Juvenile profuse bleeding, threatening the life and health. Long-term moderate due not amenable to bleeding therapy. Suspected organic pathology of the endometrium or uterus. Therapy of completed juvenile bleeding stage. Dr. Schemi? But mhm, I rated our time is over. Anti-anemic therapy, anti-inflammatory therapy, antibacterial disintoxication therapy. And if talk about other classification, we know that have new classification system FIGO, and these classifications includes PALM and Cohen. PALM includes polyps, adenomyosis, leiomyoma, and Cohen, coagulopathy, ovulatory dysfunction, endometrial bleeding, iatrogenic bleeding, and not yet classification bleeding. PALM can be visualized but not cause abnormality uterus bleeding, and Cohen may cause abdominal uterine bleeding but not be visualized. Type and cause of abdominal uterus bleeding: cyclic, intermenstrual uterus bleeding, and unpredictable. You talk about cause predictable, heavy menstrual bleeding, and it includes Doctor, so I continue, okay?
Okay.
Causes abnormality uterus bleeding. Very often this is bleeding development reproductive period and menopausal, premenopausal period. It is can be predictable abnormality uterus bleeding and relationship with adenomyosis, leiomyoma, coagulopathy, and endometrial dysfunction. If talk about intramenstrual bleeding, we know that endometrial polyps can develop in menorrhagia, and unpredictable causes heavy menstrual bleeding, cyclic bleeding, ovulation dysfunction, endometrial hyperplasia or malignancy, and iatrogenics. Diagnosis of abnormal uterus bleeding, medical history, physical examination, general and gynecological, laboratory test, general blood analysis, study of hemostasis, pregnancy test for chlamydia and other hidden infection. These are assessment methods: ultrasound pronounced, magnetic resonance image, office hysteroscopy, endometrial biopsy. At the age of the more 14 years, using hysteroscopy and curettage, these higher oncology risk, this intrauterine pathology. Treatment of abnormal uterus bleeding. The choice of therapy is determined by the etiology of bleeding, the clinical situation, the desire of the woman to preserve reproductive function, the need for contraceptions, concomitant extragenital pathology. In the absence of organic pathology, drug treatment, for example, using dufaston and utrogestan, and this is drugs have mechanism actions, drugs curettage. This is drugs curettage we are using before 35 years. After 35 years, bleeding stopping, only curettage. This includes stopping acute abnormality uterus bleeding, conducting anti-relapse therapy, and treating chronic abnormal uterus bleeding. Scrapping is not first line of therapy before 35 years. After 35, it is preferred. Affects the pathologic line. If talk about polyps, abnormal uterus bleeding may be asymptomatic, may cause abnormal uterus bleeding, may spontaneously disappear, and we are using only polypectomy and scrapping. Adenomyosis, the frequency spread of 5 or 70%. The relationship between adenomyosis and the genesis of normal uterus bleeding remains unclear. Using medication, drugs, progesterone, combined oral contraception in continuous mode. If talk about diffuse form adenomyosis, we can using hysterectomy. Leiomyoma, a cyclic uterus bleeding. The cause of a cyclic uterus bleeding may be leiomyoma affecting the molecular mechanical of endometrial hemostasis, using medicamentation treatment and surgery treatment. Medicamentation treatment, curettage, tranexamazide inhibitors, progesterone, and continuous mode. If talk about surgery treatment, we are using myomectomy, hysterectomy, uterine artery embolization, focused ultrasound ablation. Malignanizations and hyperplasia. Therapy depending on the type of endometrial hyperplasia, and this is hyperplasia relationship, this classification. If it is polyps hyperplasia, only scrapping. If it is hyperplasia, this enlarged endometrium, only scrapping using. But after after scrapping this hyperplasia endometrium, we can use progesterone line drugs. Malignancy, endometrial cancer, it is only hysterectomy. Coagulation, ovulatory dysfunction, endometrial change, iatrogenic, unclassified bleeding, non-hormonal and hormonal hemostatic therapy, non-hormonal fibrinolysis inhibitors, non-steroid anti-inflammatory drugs, vasopressin analgesics, increase factor 8. Hormone therapy, progesterone line, combine oral contraception, danazol, gestrinone, gonadotropin-releasing hormones agonist, and intrauterine device, dis-levonorgestrel Mirena. Treatment of acute abnormal uterus bleeding. Acute abnormal uterus bleeding is an episode of bleeding in the non-pregnant, requires emergency treatment to prevent future blood loss. Tranexam orally 4 milligrams, 2-3 per days, 2-3 grams per days, and 10 milligrams every 8 hours. Conjugate estrogen 25 milligrams every 4-6 hours. Oral estrogen and combined oral contraceptives 5 or 7 days, followed by dose reductions. Hydroxyprogesterone acetate 16, 120 milligrams per day, or megestrol acetate 20-16 milligrams 2 times per day. Alga dysmenorrhea. Doctors, maybe alga dysmenorrhea I send in your personal account. Thank you, doctors.